I think what you realize why surgeons have a more invested interest in that is because those are becoming the real pain points for our ability to take care of patients. And, we feel as a whole that our rate limiting step should be what we need to do to our patient at that time. And our focus should be primarily on that. And so when all these outside forces affect my ability to focus on what my primary focus should be, that becomes a major pain point that I'm going to take interest in and try to help solve that problem or make it a little bit better for everybody else, right?
From the basement to the boardroom, from ideas to innovation, you're listening to the Beyond Clean podcast, the central nexus for the people, processes, and products that are pushing the sterile processing industry forward. Each week, you'll encounter diverse perspectives from subject matter experts across the country and around the globe. Frontline technicians, CEOs, engineers, and entrepreneurs with a common goal to help you fight dirty. Every instrument, every time. Whether you are tuning in for education or inspiration, we're glad you're here. Now, turn on those washers and turn up the volume. It's time to go beyond clean.
Today's episode is featuring Dr. Derek Donegan, orthopedic trauma surgeon at UPenn, and a great theme season, Hank, talking to surgeons who have taken an interest in sterile processing. I remember we would just kind of take an episode or two and sprinkle it in, and now it's on the rise. Dr. Donegan is actually going to tell us from his perspective why he thinks it's on the rise as we have this interview today. But it is definitely on the rise so much that we've dedicated an entire season to talking with surgeons. The specialty and perspective that we are focusing on with Dr. Donegan in today's interview is trauma surgery. And we both know you can't predict volume or case volume for trauma, at least not day in and day out. It's always a surprise. And Hank, I'm excited to talk to him about what matters the most to him when we're talking about instruments and instrument trays and what's needed to be able to do cases when, again, you can't plan for them. These things are popping up when they happen.
Yeah, Justin, it just takes a shooting, a car wreck, a bus wreck, like any number of things can just overflow your ER at a moment's notice and then overflow your OR. The title of this episode is Need It Now. And that's true for every instrument, every surgeon, in every setting out there. Everybody wants their instruments now. But there's something unique and special about that trauma conversation that I really want to get out today, and what the nuance is, how they compare to other specialties out there. And then, as you alluded to, the impact that has on how sterile processing can serve them.
A great interview with Dr. Derek Donegan coming up next. I'm Justin Poulin.
And I'm Hank Balch.
From 17 Studios, you're listening to Beyond Clean, the global voice of sterile processing.
With us now is Derek Donegan, orthopedic trauma surgeon at UPenn. And Dr. Donegan, I've been really interested in having you on because I feel like trauma surgery and just what happens to the instruments and the resulting needs of the instruments is really incredibly important. And of all the different topics that we've had, I think this one's going to be a lot of fun. And so you obviously work in a unique setting, a high pressure setting. Not that surgery isn't high pressure to begin with, but I'm interested to get your take today. So thanks so much for coming on the show.
Absolutely. It's a pleasure to be here. Looking forward to talking about this as well. So it'll be fun.
So why don't you talk a little bit about your training and how you find yourself working as a trauma surgeon today?
Yeah, so it's a process, that's for sure. At a very high level, 4 years of undergraduate college and then 4 years of medical school. And then after that, I chose to become an orthopedic surgeon, which was 5 years of post-medical school training called residency. And then at the end of residency, people choose either to go into general practice or to subspecialize into a certain area and do what we call a fellowship. My passion was drawn to orthopedic trauma surgery. And so I did a 1-year orthopedic trauma fellowship and then started my career as an orthopedic trauma surgeon. So it was, 14 years post high school of education to become an orthopedic trauma surgeon.
What was it about trauma? Like why that subspecialty?
That's a good question. When I really sit back and think about it, it's the temporal relationship to somebody getting hurt, doing something that can physically make them better and seeing them recover. It's very black and white. There's a lot of areas of medicine that are gray, right? You have someone who has hypertension. They don't feel it. You ask them to take a medication to make them feel better. And sometimes they do, sometimes they don't. You have a person who drives their motorcycle into a wall at 100 miles an hour and has a broken femur, broken tibia, broken pelvis. You need to fix them. And then the shocking part is, isolated femur, they walk out of the hospital sometimes. And that's just, to me, it was so remarkable of a way to be able to influence people's lives kind of at almost their worst and most vulnerable moments. So that's kind of what drew me to it.
Yeah. It's interesting. I definitely understand that even as I was trying to find my way as a nurse and what area I would work in. And I definitely was drawn to similar situations. Hospice was one, ironically. It wasn't necessarily that people got better, but it was more about the feeling of being productive and knowing that you had an impact and that you were kind of in alignment on all the goals. And that abstractness or the art form of medicine that you describe, like with blood pressure, kind of finding your way to resolution. It's really frustrating for the patients. And I found that was hard for me. And I can kind of relate to that, what you're talking about with trauma. What are some of the other subspecialties for orthopedics specifically versus trauma?
Yeah, so orthopedics broken down. So like joint replacement or what we call adult reconstruction, which is primarily, hip and knee replacements, shoulder and elbow, sports medicine, hand and upper extremity, which is mostly hand and wrist type of work. Orthopedic oncology, which is dealing with musculoskeletal tumors or oncologic processes. Foot and ankle, which is, focusing on the foot and ankle area, spine, and pediatrics, which is dealing with younger patients, typically under the age of 18 or 16.
So there's still a lot of overlap for you. Maybe not the oncology piece, but all the others still come into play for you when you're doing orthopedic trauma, right? And so there's some overlap. Do you wind up in situations where you have to collaborate with surgeons from those other subspecialties as you're kind of dealing with a trauma patient?
Yeah, sometimes. I mean, it really depends on what's wrong with them. I would agree. One of the things I really enjoy about orthopedic trauma is that, every day is a little bit different. I could wake up and operate on a shoulder, an elbow, a hip, and an ankle all on the same day, which is kind of nice. But yeah, sometimes when, we get some complex injuries that might require complex joint replacements or something of that nature where you need to collaborate with our arthroplasty colleagues or our shoulder and elbow colleagues or, a very common one actually recently. This is a wild story, if you don't mind. A gentleman was driving down the highway and got run off the road by a truck and his arm was hanging out of the window and got cut off. And he came in with his arm. The EMS brought him in with his arm. And I work hand in hand with our hand and upper extremity microvascular surgeons to reattach his arm. I did the bony work. They did the vessel and nerve work and reattached this individual's arm. So that was kind of I think that happened in June, a recent example of us collaborating right then and there on the spot for an acute trauma.
That's incredible. Seriously.
Yeah, it's pretty wild.
Yeah. Okay, it's hard to move on from that. I'm like sitting there digesting that a little bit. Yeah.
I mean, it was wrap right there, Justin.
Yeah. I guess the last question I have for you as we kind of tee up, we're going to start talking about instruments and, the bane of just about every organization's existence, which is preference cards, especially as it relates to instrumentation. It seems like it's always an ongoing challenge. But before we get there, if you were to kind of take trauma, and I had you differentiated a little bit from other subspecialties, but I want to get a little bit broader as we kind of back out of that conversation a little bit and say, what do you think makes trauma so unique, not just for orthopedics in general, but higher than that, like general surgery, all the other different specialties. What makes trauma so different than those?
Yeah, I think it comes down to, and this is kind of what we're going to allude to and talk about, is the elective versus non-elective nature of things. In trauma, orthopedic trauma, it runs the gamut, which is actually really nice, from emergent, urgent situations to elective, or what we like to call cold trauma, so hot trauma and cold trauma, versus the majority of other subspecialties in orthopedics are primarily elective. Not always, but primarily elective situations where you have time to plan, you have time to understand what your instrument needs are, what your implant needs are, what your staffing needs are, all of those things. And it allows you, the luxury of time, if you will, to make sure you have all the pieces in place. Whereas in trauma, orthopedics or general trauma, that can change very rapidly when you have something or someone come in that needs to go to the operating room in a more expeditious way. You don't have as much time to plan. And, we're big planners, even when you don't have time to plan. There's a, quote out there that says, if you fail to plan, you plan to fail. And so, that the rapid sequence of understanding the needs in an emergent situation, I think, definitely changes or highlights the difference between trauma versus other elective practices.
I just think that is such a great way to really differentiate our conversation today, because the sterile processing technicians out there and managers, it's like trauma is just one of those things, like you said, you can't plan for. And yet having a nice operational plan for sterile processing to run smoothly is the goal for everybody. And then all of a sudden you find yourself working in a level 1 trauma facility and everything kind of goes out the window because you can't predict volumes. You can sort of get an idea. I'm sure there's some predictability to caseload just statistically, but you still can't predict volumes from one day to the next. You might be able to look at it and say, yeah, we get on average this many trauma cases a year. So we kind of know what our inventory needs to look like. But just reprocessing trays as more and more trauma cases come in really can put a lot of demand on the organization. And so I think this is an area where, substitutions matter, being able to really understand the instrumentation that's required. And it pulls us right back into that topic of conversation I was teeing up, which is instrument preference cards. And what a challenge that is. Can you talk about it from your perspective when you're looking at those preference cards or what your instrument needs are? I'm sure there's like some areas where like there's some non-negotiables in there, and then there's others that you're a little bit more flexible around. What's your perspective on the instruments?
Yeah, I think, the preference cards, I think, is that's a whole big Pandora's box if you really want to open it. I think, in current situations, the majority of preference cards are still manually updated and organized. And it takes a fair amount of workforce and work to actually keep them up to date and to change them. And so it's not uncommon that preference cards, as soon as they're updated, that they're out of date. And so I think that's, you constantly chase your tails when it comes to preference cards. And the default, I think, especially in orthopedic surgery in general, whether it's trauma or non-trauma, because it's such a heavy implant dependent specialty, is to, like to say, bring the kitchen sink, right? Nobody in the process wants the surgeon or the patient to be in a situation where they don't have something that is needed. And so the default is to add and not necessarily subtract from, preference cards or needs or what's requested. And so that just, as that creates even more of a burden on a system that's trying to keep up with an evolving timetable of instruments and things that needs to come through the system.
Yeah, like Justin mentioned, working in a trauma facility of any level, but level 1 especially is, what you're signing up for as a sterile processing technician, or you learn very quickly that, hey, we're not in Kansas anymore if you're level 1 trauma. Specifically going into what you're saying, you're bringing everything in the kitchen sink in. And many times as it's coming down for that reprocessing cycle, we need it right back up as soon as possible. And then you got competing interests of other trauma procedures coming through and other trauma instruments. And it's not a linear, it becomes much more chaotic in that flow. And then add on all the other cases that are elective in one sense, but once they're scheduled, they're on. The patient's there, the surgeon's waiting. Those instruments got to be ready just as much as any other instrument. So it does come down, to a lot of the balance of priorities, but even the balance of space and inventory, which that's kind of what I want to get to next. Like Justin set this up a little bit, but I want to go back to it on kind of teeing up the previous episode in this season. We talked to Dr. George about how surgeons are taught. He's a professor. And we asked the questions of him, like how do you teach instrumentation? And I'm going to kind of pitch the question back to you in a different way and say, as a trauma surgeon, how do you decide what instruments you want to use, right? Like, where is that coming from? Is it just how you were trained, the school you were trained in, your mentor, your professor? Is it all the new bells and whistles? Like, what dynamic do the medical device reps have on the instrumentation decisions that you make? Kind of walk us through some of that.
Yeah, so I think there's two avenues to look at. There's instrumentation and then there's implants. And with the implants come instrumentation, right? So there's general instruments that we use on a regular, like certain retractors, like Hohmann retractors or Charnley retractor that, self-retracts the skin and the soft tissue around where you're working. And then there's more implant or instrument specifics for these implants, which you're referring to kind of the medical device world. And a lot of that, it's a balance. Most surgeons, when they come out from training, use what they were taught on just because there's a comfort level. As we just discussed, there's a little bit of a unknown aspect, especially in orthopedic trauma, of what's coming through the door. So to limit as many variables as possible, people tend to use the implants and medical devices that they were trained on. As they move on in their career, they become more comfortable with the procedures themselves, and, new implants or instruments might be released to the market. There's an opportunity to explore them and see what the benefits may be of using a different implant compared to the one that you're currently using. My humble opinion about it, and this is how I teach our residents, is that, for probably 80 to 85% of the cases, it doesn't necessarily matter the implant that you choose to use as long as you use it correctly. There are aspects of implants that make them unique in some way, shape, or form that for that 15-ish% matters, right? I'll give you an example. Say a really distal femur fracture that might be amendable to an intramedullary nail. There's many different retrograde intramedullary nails on the market, and most of them have different interlocking screw options in that distal segment, right? And so depending on where that fracture is and what that fracture pattern is, you might choose to use one over the other based on the screw options that you might have, right? And so that might guide you. If it's a midshaft femur fracture, it probably doesn't matter.
So your kind of description here is a perfect setup to my next question, because you're describing your approach to the instruments, that you're trained in a particular place, you got comfort level with particular instruments, and you got, clinical decisions that you're making based on what you're seeing in front of you. But we know that, surgeons have different opinions many times.
No.
How does that, yeah, that was a softball. Okay. How does that work out practically in our facilities when you got multiple trauma surgeons that one sterile processing team is supporting, and then you've got preferences around instrumentation and inventory volumes? Do y'all talk to each other about those things, or is it just kind of an unspoken rule of, hey, he does it his way, she does it her way, and we're not going to try to get into each other's business when it comes to the tools of the trade?
It's a little bit of both, right? A little bit of it is, which I think we need a lot of help on, is demand planning and understanding kind of what's available and what's being requested. And so in the essence of all of that, there's, the time to requested data or instruments is really important. Just again, an example, any company's small fragments locking set is probably a very high used implanted instrument set for orthopedics in general. So there might be the hand and upper extremity surgeons that are operating in a day, the foot and ankle surgeons that are operating, and orthopedic trauma surgeons that are operating. And they all ask for the small fragment locking set of a certain company. If we only have 2 of them and 3 surgeons are requesting them, then something has to give. And that, the process, as you know, is especially when the implant world is there's the sets and instruments that are, owned by the hospital. There are the sets and instruments that are consigned to the hospital. So those live there mostly, right? They're the responsibilities of the hospital. And then there's the loaner sets where the medical device companies can bring in more sets and loan them to the hospital for that specific procedure. And so, that takes time to plan because of the sterilization process, right? I think most sterilization processes, except for some very, quick turnovers, which are not typically the standard, take at least 4 hours to turn over a set, right? And so if you have a set requested at 6 a.m. and that case is going at 8 a.m. and that's a loaner request, there's no way that set will be ready in time, right? And so timing, I think, is of the essence in that regards and understanding demand planning. And so from my perspective, it's, how do you communicate your needs as soon as possible? And then if your needs are communicated and say your case card is put together, right, for that, elective case, but say something comes in the middle of the night and what that person needs is on that case card, it gets taken off. That's not uncommon. That the communication loop has to be there to say, hey, this was on there. Now it's not. We need to replace it. And so in my humble opinion, it all comes down to how we as a system and people communicate with each other the needs of what the system has.
Yeah, you're getting into the weeds on that case card, kind of stealing, but that's the weeds we live in, right? That's happening. And in a trauma context, to your point, it happens more often, and it's easier because of everything else that's going on and the lack of time. It's easier to let those things drop through the gaps and miss them. So yeah, that's a great call out. Speaking of challenges like that, I do want to ask you, what are the common instrument issues that yourself and your trauma peers that you encounter in your daily surgical experiences? And then how do these issues impact your ability to care for the patient? Because that's something that sterile processing doesn't necessarily get to see.
Yeah, I think there's a couple of things. I think number one is availability of sets, which we just talked about. I would say that's not necessarily on sterile processing other than when those sets need to be turned over. That's not an uncommon thing, right? I have a partner that I work with and he does the same type of stuff I do. He'll use a set on Monday that I requested on Tuesday. If that set's not turned over, it won't be available for Tuesday, right? And so understanding that when these sets come down, they need to be turned over. And granted, there's limitations to what the system can manage, but it's important that happens. The other two kind of really big things that are difficult is when sets are incomplete. For instance, this happens not on an infrequent situation, but again, I'll use a small frag set, for instance. If you need to put a 3.5 millimeter screw, you need to drill with a 2.5 millimeter drill bit. If that 2.5 millimeter drill bit is not on the set, that's a problem, right? And so that makes that set not useful. And that small frag set might have 20, 40, probably 23 instruments on the top tray, plates and screws and some other instruments on the bottom tray. So to open up a whole new set just for one drill bit is, again, a big issue for the system, but it makes that case not even possible. And then the last one would say is when, the sets are sterilized and then they come up and they're contaminated for whatever reason, right? There's some bioburden in the set, or the soft drapes wrapping there's a hole in it or whatever. And then that takes that set out of the system and out of use. And if you're in a situation where we don't have a backup, or that was the fourth one of 4 sets, there's a challenge. And sometimes it's not as big of a deal because, patient's not in a room yet. Room's just getting set up. Sometimes it's a bigger deal when patient might be in the room and might be asleep, and you have to make a different decision of what you might use to fix that person's problem.
We were talking about the loader trays, and you talked about, consignment and hospital owned inventory. And I thought that really highlighted sort of the vendor's role well, which is something that we didn't really focus on until you brought that up. And I kind of want to triangulate the conversation a little bit, right? Because you really have three different main stakeholders. You have that vendor relationship on those loaners, you have sterile processing, and then you have the operating room. And the three are trying to work together the best that they can. But obviously there's in any process, and especially, there's lots of humans involved in that. There isn't like a single technology that you could just drop in and immediately communicate effectively and do demand planning amongst all parties. So anytime you have different humans kind of involved in working a little bit in silos, but also in concert with each other, there's going to be opportunities for improvement continuously. And sometimes it's related to turnover, but I kind of want to take a higher level view than that and say, just as a department in sterile processing operating room, or bringing in the vendors and the manufacturers themselves, or it could be third party distributors, I suppose, because that might be your direct contact, right? But where are the greatest opportunities for everybody to serve you as the surgeon? So I'm going to kind of triangulate that, but I'm coming back very directly from your perspective. Like, where are the breakdowns, or where is the greatest breakdown that would have the biggest impact on your ability to do your job better when you kind of look at all three of those stakeholders in the process that impact the care you're able to deliver?
Yeah. I mean, I think, when I think of the sales representative or the medical device representative, to me, they do play a really integral role. And the reason why I'll say that is because we're siloed in our institution, right? So I know what's going on in our institution. And if I'm a very well aware surgeon, I know the limitations of how many sets we have. If I'm a well aware surgeon, most surgeons we don't really understand that well. But then when you look at the bigger picture outside of your institution, who's going to troubleshoot some of those issues for you, that starts to fall on the medical device individual, right? If you request a certain implant from a certain company and that's not available at your hospital for whatever reason, they don't want to lose the business, right? And so they understand what else is going on in their area that allows them to go and maybe borrow it from somewhere else, or take it from somewhere else, or get it from a forward stocking location, whatever it may be, in order to keep a customer. So I think they play a really integral role in the process. And I would just say, it comes back to my previous comment about communication and timing of communication. And I think, as soon as the need is known, the communication needs to happen, and all parties need to know at the same time. And I think that is kind of a critical aspect of any demand planning is, as soon as, person zero knows, everybody needs to know. And that will allow at least the most amount of time to prevent any of the balls from falling through. And just for a little ploy, because you mentioned there's no technologies out there, in my other job, that's kind of exactly what we're doing, is working on the technologies to enhance and improve, what we call time zero communication, right? At that point of order, everybody knows that in the process.
So that's really good to know, because, that is a challenge. I do see that communication as being like one of the biggest issues. And we talk about all the human parts. Communication is almost entirely human. We're getting better at building in, technologies that can help do that, but making it actionable, and then speed, especially as it relates to trauma, is of the essence for all the reasons that we talked about, during this discussion. So, Derek, I think this was a phenomenal conversation. I think you really differentiated the trauma piece, and we're all about networking and getting people connected. So you kind of teed up a little piece there at the end about, trying to make some improvements in what you're calling time zero communication. So speaking of communication, how can people network with you, communicate with you? You clearly have an eye for sterile processing. And that's actually one of the most encouraging things about this season is just hearing how much interest surgeons are taking. I mean, just what you said about the inventory and knowing if I'm an aware surgeon, I know what the inventory is and what the inventory limitations are. Again, lots of encouraging sort of conversations we're having for the audience. But how can people connect with you? Maybe they've got some insights for you as you continue to work on that time zero communication tool.
Yeah, I mean, a point on our side real quick about that is I think what you realized why surgeons have a more invested interest in that is because those are becoming the real pain points for our ability to take care of patients. And, we feel as a whole that our rate limiting step should be what we need to do to our patient at that time. And our focus should be primarily on that. And so when all these outside forces affect my ability to focus on what my primary focus should be, that becomes a major pain point that I'm going to take interest in and try to help solve that problem or make it a little bit better for everybody else, right? So I think that's just a critical thing for us as surgeons and physicians to do to improve the process. As far as contacting me, my email is probably the best way. I'd love to reach out. Derek.Donegan@gmail.com is the easiest one. It's the easiest one to remember and the easiest one for me to track. So feel free to reach out and be glad to entertain more conversations and answer more questions as this has hopefully come across a clear passion of mine to improve this process.
Oh yeah, it definitely did. And I'm going to go ahead and spell it out for everybody. So Derek is Derek, then you do dot and Donegan, Donegan. Many of you out there might have figured that out, but I just want to make sure you know, and it's at gmail.com. Dr. Donegan, phenomenal interview. Thanks for taking such a great interest in sterile processing and also trying to impact change to make everybody's work lives a lot easier and then, the actual lives of the patients a lot better.
Absolutely. It was truly my pleasure and it's an honor to be on here. I follow you guys. So, this is great. And I think you guys are doing fantastic work. So keep it up.
That was Derek Donegan, orthopedic trauma surgeon at UPenn. And Hank, this really is a whole conversation around demand planning and inventory management that I just did not expect to have with a surgeon, to be honest with you. Not this level. I know they understand demand planning in terms of I need this tray and I need it to look like this and have these instruments in it. But to actually have the operational awareness of where their limitations might even be due to how much inventory they have, that was definitely more of a shocker for me in this conversation. And I think it's really an important one to be having. We just have talked about this, people working in their silos and, inventory, it doesn't matter where it's stored. If it's stored in the OR, if it's stored in SPD, at the end of the day, it impacts everybody that has to deal with, surgical services and is in that whole flow and process.
I'm telling you, man, I was having flashbacks this whole episode from my time managing and directing a level 1 in Kentucky. And then I moved down to Texas and we added pediatric trauma. And it's a whole nother world, like you said. And Camille's alluded to, too, the chaos involved on the instrument side of things. And you mentioned, too, if the inventory is in the OR, well, that's great because they love it being a little bit closer. It's less, feet to travel, but then it causes all kinds of other headaches for sterile processing because then it's more difficult to control the inventory, control the room, what's going in, what's going out. Huge opportunities. Anyone tuning in from any side of the equation, there is still a lot of growth that's needed to bring our trauma capabilities in sterile processing up 1, 2, 3, 4, 5 notches. We got a long way to go until we can really feel comfortable. And we've got the training, we got the inventory, got the demand planning, got the communication and all the data. So hopefully this sparks some entrepreneurs and some innovators out there, to do some thinking, do some collaborating and make some positive change.
Well, and Derek is one that is engaging in that. So if you do want to network with him, again, it's Derek, Derek Donegan, Donegan @gmail.com. Another great episode in the books. Hank, really enjoyed this conversation, but I've been enjoying this season immensely. And so the best way to listen to our shows, well, at least from our perspective, is to download the smartphone app for iPhone or Android. We've got bonus content in the app, etc. You'll find us wherever you're listening to podcasts. I doubt this is the only podcast that you're listening to. And if that's the case, you probably are listening on Apple, Amazon, or Google Podcasts. But if you have not started to listen to other podcasts, and this is the only one, certainly we recommend lots of other podcasts, including sister podcasts on our network, First Case, Power Supply, Transmission Control. They have all their own apps, but are also on all sorts of podcast platforms, not to mention Stitcher, iHeartRadio, Spotify. If you're listening to a different one, you'll find the whole family of podcasts there. And I do want to remind everybody that you can reach out to us. Maybe there was an episode that you listened to that you really enjoyed or made a difference in your daily practice or on your organization. Maybe there's even a guest you'd like to get in touch with, just as we gave out Derek's information today. Certainly reach out to us directly. Hank and I are both available for connecting on LinkedIn, but you can also send an email to the show at info@beyondclean.net. So on behalf of Hank and myself, thanks for listening to this week's episode of Beyond Clean.